Hello, I am Ingmar Blumcke and I'm a neuropathologist from the University of Erlangen in Germany. I would like to talk to you about a new proposal for an international consensus classification of mesial temporal lobe epilepsy with hippocampal sclerosis. mTLE-HS is a common and often difficult to treat epileptic disorder that can be drug-resistant, and patients with drug-resistant mTLE may be considered for surgical resection of the mesial temporal lobe. However, post-operative seizure control is variable and difficult to predict for each patient. The ILAE has created a task force to review the existing data, and our commission is to propose a first international consensus classification system to define structural brain lesion variations in mTLE-HS patients. Our task force is suggesting 3 specific clinico-pathological subtypes that can be characterized by structural lesion patterns, but which may also be associated with different risk factors for seizure control or cognitive impairment following surgery. So type 1 is most common and presents with early seizures, a clinically silent period and onset of chronic epilepsy in teenagers. It is histopathologically well characterized by loss of neurons in the so-called CA1 and CA4 sectors. However, these patients will rapidly develop drug resistance and benefit from selective surgical resections. There are also 2 atypical forms of HS. Patients with type 2 HS usually present with later disease onset and rapid seizure progression, but may not suffer from deleterious memory decline. Indeed, the pattern of cell loss, of pyramidal cell loss, is confined predominantly to the CA1 region. As a matter of fact, we observe preservation of those neuronal cell populations in the dentate gyrus, which are particularly important in short-term memory formation. Patients with HS type 3 will usually suffer from more widespread structural lesions in adjacent brain regions, such as inflammatory disorders. And histopathologically, looking at the microscope, we see the predominant cell loss of neurons in the CA4 region. As a consequence, surgical treatment may consider larger brain areas to be resected, and outcome may thus be less favorable. We hope that this 1, 2, 3 consensus classification will be helpful to develop better tools for a reliable pre-surgical diagnosis of mTLE subtypes in the near future. Such efforts can be only achieved in collaborative team networks, and our ILAE task force will further serve to achieve this goal.